Good morning. My name is Saron Nair from Department of Conservative Dentistry and Orthodontics. My today's topic is access cavity preparation. I'm just going to go into the basics. So we go for an introduction, components of root canal system, definition, objectives, guidelines, and armamentarium. Moving on to the introduction, dental pulp presents with a variety of configurations and shapes throughout the dentition. Therefore, a thorough knowledge of tooth morphology, careful interpretation of radiographic documentation, and adequate access to and exploration of pulpal space are prerequisites for all root canal procedures. Components of root canal system. The dental pulp is often referred to as root canal system. The outline of the dental pulp corresponds to the external contour of the tooth. Factors such as physiological aging, trauma, pathosis can modify its dimensions through dentine or reparative dentin. These are the components. Now, the entire root canal system comprises of your pulp chamber, root canal, and apical foramen. You have other things like pulp horn, you have the orifices, then you have sometimes the percussion canal or a lateral canal or accessory foramen. Now, the canal configuration varies. So, Bertolucci's canal configuration is the most widely accepted and used one. It's basically divided into three categories depending on how many canals are there at the apex. So, in category A, you have only one. Category B, you have two. In category 3, you have 3. Going on to the classification of isthmus. Now, the importance of this is that in some types of isthmus, especially like your type 4 or even type 2, there will be necrosed pulpal tissue present in the isthmus area, which without thorough irrigation and cleaning and shaping cannot be removed. And this will later lead to reinfection. Moving on to the apical consideration. Now, for a successful root canal therapy, the apical third of the tooth creates a big dilemma for everyone. Now, there are mainly 3 anatomical landmarks that we have to know. That is apical constriction, cemento-dental junction, and apical foramen. The apical constriction is the reference point of termination for enlarging, cleaning, shaping, and filling. It is about 0.5 to 1.5 mm coronal to the apical foramen. The location of the cemento-dental junction varies considerably and is 1 mm from apical foramen. The apical foramen is the circumference or rounded edge like a funnel or crater that separates termination of cemental canal from exterior surface of root. Being recommended to the following termination points. Very, very important again. 1 mm from apex when no bone or root resorption has occurred. 1.5 mm from apex when only bone resorption is present. And 2 mm from apex when both bone and root resorption has occurred. Moving on, definition of access cavity. Access cavity preparation is defined as a preparation of that part of the cavity from the occlusal table to the canal orifice. This is according to English. Moving to the objectives of access cavity preparation. Remove all caries, conserve sound tooth structure, completely unroof the pulp chamber, remove coronal pulp tissue, locate all root canal orifices, achieve straight line access to the apical foramen or to the initial curvature of the canal, establish restorative margins to minimize margin leakage of restored teeth. Ingles objectives are, we have 5 of them. To penetrate through the occlusal surface. The second objective is to find the pulp chamber. Third is to unroof the dentin that covers the pulp chamber. Fourth, you have to obtain uniform contact of the file with the access cavity wall. Fifth, to obtain the straight line access. Now, more important than Ingles objective is the Krasner and Rankos principles of access cavity preparation. First, you have the law of centrality. That is, the floor of the pulp chamber is always located in the center of the tooth at the level of the CEJ. Law of concentricity. The walls of the pulp chamber are always concentric to the external surface of the tooth at the level of CEJ. That is, the external root surface anatomy reflects to the internal pulp chamber anatomy. Law of the CEJ, the distance from the external surface of the clinical crown to the wall of the pulp chamber is the same throughout the circumference of the tooth at the level of the CEJ. First law of symmetry, except for maxillary molar, canal orifices are equidistant from a line drawn in a mesodistal direction through the center of the pulp chamber. Second law of symmetry states, except for maxillary molar, canal orifices lie on a line perpendicular to a line drawn in the mesodistal direction across the center of the pulp chamber floor. Finally, you have the law of color change, that the pulp chamber floor is always darker in color than the walls. Next, you have the first law of orifice location. The orifice of root canal is always located at the junction of the walls and the floor. Second law of orifice location, the orifice of root canals are always located at the angles in the floor wall junction. The third law of orifice location is that the orifices of the root canals are always located at the terminus of root's developmental fusion lines. The preparation of access cavity through lingual or occlusal surfaces. For anteriors, it is lingual, and for posteriors, it is occlusal. Moving on, removal of caries and defective restoration before entry in the pulse chamber is mandatory. Removal of unsupported tooth structure. Creation of access cavity walls that do not restrict straight line access passage of instrument apical foramen or initial canal curvature. Sufficient tooth structure should be removed to allow the instrument to be placed easily into each canal orifice without interference from the canal walls. Therefore, the access cavity design not only depends on orifice location but also on position and curvature of entire canal. Delay of dental dam placement until difficult canals have been located and controlled. Rubber dam must be placed once the roof of the pulse chamber has been penetrated and the canals are identified. After the access cavity is prepared, only then the rubber dam should be placed. Location and flaring and exploration of the canal orifices. Sharp endodontic explorer is used to locate the canal orifice. All canal orifices and the coronal portion of the canals are flared to make instrument placement easier. Canals are then explored up to the apex with small pre-curved K-files. Now, inspection of pulse chamber using magnification and adequate illumination. Nowadays, the endodontic microscopes or loops are used. It makes things a lot easier. In case you don't have that, we have to use the various colors that can be seen. That is, like enamel is white, dentine is yellow, floor of pulse chamber is gray, root canal orifice is dark gray or black, pulp stone is pearly white or dark yellow. Then tapering of the cavity walls and evaluation of space adequacy for a coronal seal. Very, very, very important again. Coronal seal, in between, if you're giving multiple appointment RCT, your coronal seal should not dislodge in between the appointment. This will lead to unnecessary complications and discomfort for the patient. So you need at least 3.5 mm of temporary restoration to provide an adequate coronal seal for a short time. Now, other additional burrs are used, like your round carbide burrs, number 2, 4, and 6. You have also a access burr with a tapered fissure burr with a round end. That is a different kind of an access burr. To remove caries, to create initial external outline form to penetrate the pulse chamber roof and to remove the roof. Also, the most important instrument is this burr. It's called an endo-Z burr. The best feature of this burr is that it is a non-end cutting burr. It only cuts in lateral. So even if you give apical pressure, this will not lead to perforation, unlike the round burrs that we have discussed in the previous slide. To do access cavity preparations through metal ceramic crowns or full metal crowns, you need something called a trans-metal burr. It's shown in the diagram. These are used. It can go through porcelain or metalloceramic restorations. Now, for orifice location and for removal of calcifications, you have extended shank round burrs. They are attached to slow speed hand pieces. And the biggest benefit of this is that because of the long shank, when you angulate your burr, you can see the inside of the pulp chamber and you will be able to direct the burr directly onto the required area or orifice. These are called as Munt's discovery burrs. After the orifice is located, you need to enlarge the orifice. For that, you have gauge clearance drills, which helps in flaring of the canals, which will later help in ease the process of cleaning and shaping. Hand instruments like DG16, which you have already seen, and also JW17 are used to identify calcified canals. The simple operative explorer can also be used to detect any pulp chamber roof, particularly in the area of the pulp horn. The latest, you have your ultrasonic tips and unit. These are used to trough and deepen the developmental grooves and to remove tissues from and explore canals. The benefit is that they are smaller than round burrs. Thank you.